Swayam Prabha. Digital India. Educated India.
Welcome friends once again to our NPTEL MOOC module on health economics. We have been discussing in continuation to our discussion on financing issues. There are some linkages we have given in earlier weeks. Even our next week is also going to discuss some of the aspects of financing as issues as part of health system. In this week, we are discussing financing and insurance in healthcare, and that is very relevant to understand health economics in detail. Just to recap our previous lecture, we discussed the theory of health insurance, welfare gains from health insurance, patient payments, reimbursements, types of health insurance, etc. In this lecture, we will be emphasizing on asymmetric information in economics and in economics of health in particular. We will be emphasizing on moral hazard. Then within this we will be discussing on what is called moral hazard, what are the different types, their determinants, how to limit moral hazard, how to control moral hazard, and what are the evidences of moral hazard, then preventive care and moral hazard, and the last one to discuss is upside of moral hazard. Then what is asymmetric information? You might not have read in micro in detail. It used to be explained in the advanced microeconomics theory. However, if you have not read, it is good to follow it from here. I will just clarify. It is all about AIE, that is asymmetric information in this context, refers to a situation where one party is possessing more knowledge or information than the other, that leads to potential market inefficiencies, adverse selection and moral hazard. Reducing this information asymmetry could lead to decrease insurance cost, improve product offerings and an increase in insurance coverage within the nation, as mentioned in the recent survey of economic survey published in 2021-22. So, what are the problems due to asymmetric information? Largely due to information gaps existing, defining market inefficiencies, and how it is famous, and it is due to the work of George Akerlof, Michael Spence and Joseph Stiglitz in their referral work of 2001, by which they received the Nobel Prize. All three shared the Nobel Prize. And Akerlof especially for the paper 1970 essay that is called the Market for Lemons, published in QJE, Quarterly Journal of Economics, discuss about adverse selection, moral hazard, principal agent problems, signaling. Spence especially advocated in the year 1973 of his PhD thesis, and screening mentioned as clearly by Stiglitz in the work. Hence, we will be discussing more details of moral hazard problems, especially in health insurance. So, in health insurance market, buyers of information, that those are the patients, have little to no information of until they purchase, or sometimes never at all. And especially in skin care case, information is available after treatment, and that is to be referred as low quality providers will have to reduce prices. Okay. So, open heart surgery cases where difficult to evaluate quality, patients may rely on the reputation of doctors. Okay. So, altruism among doctors can eliminate this problem. Reimbursement rate pre-negotiated with insurance companies, advertising, private incentives for testing can exacerbate these conflict of interest. As I already mentioned about C-section deliveries in India, and the cases are rising, and the most preferred number of cases in this case are of private hospitals. Why is it so? What are the connection with moral hazard, etc. Will emphasize in other slides. Health insurance creates informational problems in health markets. There are aspect of ex ante moral hazard and ex post moral hazard. Ex ante basically in anticipation when actions are taken, like health insurance may lead to less incentive to avoid poor health behavior. Okay. And another ex post moral hazard, basically the cost of individuals excess usage of healthcare spread over all the other purchasers of insurance. Everyone overutilizing healthcare is part of the discussion of ex post, and this is also called free rider problem as part of moral hazard. Ekerlock in 1970 explains how quality of goods traded in market can degrade the presence of information asymmetry. Okay. Design of the healthcare systems must account for this market failure, or this can lead to a loss of consumer faith and resultant under the investment in healthcare. So, let us explain moral hazard in detail. As I already mentioned, to define moral hazard, it is related to the insured individual's tendency for insurance against loss to reduce incentives to prevent or minimize the cost of loss, as mentioned in the work of Baker 1996. So, the insured individual's tendency for insurance against the loss or reduce incentive to prevent or minimize the cost of loss. Hence, it is explained in two ways. One is called ex ante moral hazard and ex post moral hazard. Ex ante, as I already mentioned, the behavior gets anticipated, that is the behavioral changes that occur before an insured event happens and make that event more likely. Okay, like skipping the flu vaccine. Flu vaccine we can people skip, or another example like consuming artery clogging cheeseburgers. The usual example for the anticipated actions before insurance is called moral hazard problem. Then ex post is basically then overuse after the insurance event, and such examples like knee replacement surgery over painkillers or taking an expensive drug like bone grow rather than a more inexpensive remedy, etc. We also give you some context where moral hazard is ex ante or ex post. The context is now the pattern we are explaining, then we will cite an example. An individual is exposed to the risk of a negative event labeled as X, and the actions can influence the likelihood of this event. The individual opts to purchase an insurance policy which provides financial coverage for some or all of the expenses associated with that event X. With insurance in place, the perceived cost of the event X for the individual decreases, and introducing a distortion of the actual consequences of that action. Due to this distortion, individual modifies the behavior in a manner that either heightens the probability of event X or increases the cost associated with its recovery. Okay, so two ways, as I told you, ex ante or ex post. So there are two implications as part of some moral hazard attached on the process. So either the probability of that event gets heightened, or it is increasing the cost associated with that. Cost may not be borne by the individual who has taken the insurance, but the overall cost increases. The insurance company remains unaware of these behavioral changes due to an information asymmetry as the contract would have been designed differently to discourage or penalize riskier behavior if such information were available. The individual's riskier behavior contributes to a social loss, since they are overutilizing or the riskier behavior in different stages result in social loss. We will also present this in our graph as the occurrence of the costly event X becomes more frequent than it would have been without the presence of that insurance. Now, just giving a citation with our own settings. We are situating nearby Haridwar, Rishikesh. So, hence we thought of our own team and citing with some names. Like you might have heard about river rafting in Rishikesh, which is considered to be one of the tourist destinations. Three friends are there: Akash, Priyam, and Nandan. So they are actually the students who own special trips to Rishikesh that included river rafting. Out of three, only Nandan, the last one, loves adventure actions. They were all part of the employee health insurance. Okay, so that means at this moment they are actually, though they are the student in IIT, but actually we are taking these names as they are working in some companies. Okay, so company's name need not be cited, not required. So basically our assumption is that they are part of the employee health insurance. Unfortunately, during a recession, Priyam and Nandan had to lose their job. As a result, their access to health insurance also gets stopped. Priyam, who wasn't a big fan of river rafting, decided to withdraw from the trip due to the risk involved, since no longer he had health insurance. On the other hand, the Nandan, who we said is the risk lover, who loves adventure life, joined with Akash, who still continues the health insurance. His job is still continues to go for Rishikesh despite not having health insurance. That means Nandan didn't have, but still he loves to be part of this trip. During the river rafting adventure, their boat capsized in an accident. Akash and Nandan suffered multiple fractures and were advised bed rest along with expensive treatment. Akash, with the help of his health insurance, completed the required medication. However, Nandan lacks that insurance, as I already told, due to recession, job loss, etc. He could not able to afford the expensive treatment and faced a catastrophic expenditure. Hence, in this context, given these three sentence or paragraph, through these three friends, what we have seen that whoever has opted for the insurance has actually utilized it. Okay, and hence Akash's decision to take the extra risk, knowing that he would be covered, will be covered. This highlights the concept of moral hazard, which we have discussed. Moral hazard in health insurance. Okay, so opted this Nandan case is fine because he is risk lover, and in that case moral hazard aspect is not discussed because he is ready to pay for it. But in this case, the payment is already made, and his Akash is preferring to go for because he knows that insurance is there. Hence, it is famous case of moral hazard. Which type of moral hazard is this? Because in anticipation action is taken that to go for trip to river rafting in Rishikesh or not. Hence, it is called ex ante moral hazard problem. Okay. Another one in from recent clip of newspaper, you can easily see that in an event of injury, you can just see I have figured out what was causing Marvin's toe to be cold. There are from the first figure you can say Marvin is being picturized, the figure is getting cold, but why is it so? the response is, I still want to take him to, I mean basically the cut mark or the injury in the finger seems to be very minor. Okay. It is visible from the figure that as if nothing is making so serious. However, he wants to cross check with the doctor. I still want to take him to a doctor just to be sure. Okay, that means since it seems that as if doctor is going to deal with the matter and will take care of these aspects if insurance is there or insurance is taken. So that post event, basically once event is happened, if the treatment is taken, in that case and decision is still taken, that means it is a exposed moral hazard problem. Okay. So, what are then the determinants of moral hazard? There are largely three. One is very necessary criteria called asymmetric information, which we have already explained, and other two are actually price distortion based or price sensitivity based. In the price distortion case, basically function of incomplete insurance is there, and function of price distortion where price is dominating, and in that case the function of completeness of insurance. So, complete insurance if it is there, that is actually distorting the price, and that way the patient might take advantage because of price changes. Hence, price distortion leads to the possibility of moral hazard. Sensitivity is another reason. If the change in price also affects, sensitivity again depends on the nature of risk being insured and how controllable it is. Okay, depending upon how sensitive the price is respective to that of the event. Hence, the cost of risk, risky action, etc., then distortion, the changes, etc., matters a lot in case of moral hazard behavior. In this diagram, we are just trying to explain the social loss that is resulted out of the price sensitivity or the price distortion. Here we are presenting without insurance what is the demand. The first diagram is without the price sensitivity. We are just presenting the simple linear diagram. We are just trying to explain the price distortion at this moment. So, without insurance, it is the choice is the price is corresponding with the quantity of the consumption. So, PU, QU, that is called without insurance, and if insurance is taken, then price gets completely distorted to PI level, and hence higher quantity is consumed, and that is basically due to the extent of price distortion. Okay. And if there are any sensitivities, then of course it will change the narrative, and we will just see how it happens. So, with insurance, effective price decreases from PU to PI and consumption increases from QU to QI. So, PU QU is social efficient one. However, PU QU should not is not the best taken because insurance is opted. So, final choice is PU PI QI, and social loss is resulted due to ex ante moral hazard problem. So, price distortion from health insurance is explained as vertical distance between uninsured price and the effective price after insurance. Okay. And we will actually explain these things. And in case of extent of price sensitivity, if it is getting changed and it is becoming now price is actually responsive enough in this diagram when it is flatter or relatively flatter. When it is inelastic, the price is insensitive. In that case, it is not the price distortion that really matters so far as moral hazard is concerned. If there is either no price distortion or no price sensitivity, then if that is the case, then moral hazard does not occur. If it is completely vertical or there is no sensitivity of the price or it is completely even fixed vertical, in that case no moral hazard occur, and hence social loss is actually 0. Okay. So, this is where we are presenting the issues of social loss. You can see, so till QI, as I already mentioned, from this till this portion is actually now over utilized, and that leads to social loss. Okay. Now, how to limit this moral hazard? There are some suggestions given, like as I already mentioned, is due to price or due to sensitivity. Insurers include provisions in their contracts that attempt to mitigate the effect of moral hazard. Extent of moral hazard depends on how sensitive the demand is to price and amount of price distortion caused by insurance. So, there are suggestions given. Out of the 5 or 3 R's used to be negligible. One, the deductibles, gatekeepers, and the monitoring. The most effective approaches are the first two, co-insurance and co-payment. It is not as though one time insurance is paid and that is safeguarding completely. If the co-insurance is taken, or co-payment is taken with certain amount or with certain percentages, that way cost is being shared, and that carries certain pressure on the mind of the patient, hence overuse might be controlled. Okay. So, we are going to discuss this. We said that how sensitive demand is to price. In that case, insurers usually does not have the control, but in the second one, insurers can reduce price distortion, like if price distortion, if it is the important cause behind, then that way co-insurance and co-payment might work, since cost sharing is considered. So, here we are mentioning one by one, that is co-payment and co-insurance rate. This reduces the social loss at the expense of increasing uncertainty faced by consumers who are no longer fully insured. Okay. So, co-insurance, which is clarified as insurance provision in which enrollees pay a percentage of each medical bill, and the insurer covers the remaining portion. That is basically a certain percentage, a percentage in each medical bill to be paid, called co-insurance. Okay. Whereas, in case of co-payment, certain amount, provision in which a fixed amount to be paid, that is called co-pay in each medical coverage. So, now we are discussing the context of social loss from full insurance plan. You can see, I think we have partly discussed, and even we are going to discuss in the next unit as well. That is on in our health system unit as well. We are emphasizing this about the systems, how it is actually controlling the social losses. So, this is the one where we already mentioned that it is QU without insurance case. An individual is uninsured, he gets or she gets what he or she pays, that is marginal benefit equal to marginal cost, hence there are no losses. And once full insured at the level of the total demand, that is QA, if it is covered, if it is complete coverage by insurance. So, that means all the access you can do it, okay, and that is considered to be the one with full insurance. When individual has full insurance, marginal cost of medical care is actually 0, and hence it is the entire one where it is overutilized, and so it is, since the individual is emitting or are bearing no marginal cost, and all the cost of access actually goes to the society, okay, and hence it is called social loss. Effective demand in case full insurance becomes upward and straight line, that is inelastic. Okay. Irrespective of price, individual purchase optimal health care, since his marginal cost is 0, which we already mentioned. Now, we are referring the case of co-payment. Co-payment you can just see once. This is the entire amount on the box is of social cost or social loss. Okay. Since individual marginal cost is 0, so entire is social cost. Now, we are discussing if co-payment is introduced, certain amount is to be paid fixed amount to be paid out of the total. So, individual is actually bearing, and the cost, hence total consumption reduces till this, you can just see. So, the total social loss actually reduces. Another case, if there are some sensitivities and that too due to co-insurance, you are actually paying certain percentage of your insurance. Yes, major percentage is covered by the insurance company, but certain percentage you are bearing, hence the social cost will be of course different, and use will be different. So, you can just see co-insurance plan rotates the insured individual's demand outward from the case of no insurance. Zero co-insurance is equal is nothing but the vertical line, which we already discussed, and that is overlaps with the full insurance line. As co-insurance rate increases, line goes towards actual demand curve, that is D. It is tilting towards the D line, and 100% co-insurance rate means no insurance line, that means it will be the original demand curve, right. So, effective demand swells to left when co-insurance are present from the case of insurance, hence less social loss as against the full protection or the full insurance case. So, now we are discussing case of deductibles, which we negated a bit because it is hardly carrying the cost sharing basis. However, if deductibles are there, still it controls the moral hazard. Deductibles are set of minimal levels of expenses below which the insurance does not help reimburse medical expenses. Okay. Deductibles may be paired with co-insurance or co-payment, or deductibles can limit the moral hazard from insurance. This is what we said in total healthcare expenses increases, hence the out pocket burden increases, that means the person is bearing the cost. However, if deductibles are there, okay, some deductibles after certain level is there. In case of deductible over insurance rate of 40%, we are saying, now we have done a 45-degree line to highlight that with the axis your rate of bearing the cost is same or at the same rate. But if deductibles are there, that means 40% is actually is covered. Okay. So, 40% 40% co-insurance region is now given, some deductibles are there. Okay. So, in that case you can just see the change tilt in the line, okay, it is no more the 45-degree line. So, it is some deductibles are there, hence we can present it differently. So, only 40% of the total health expenses are OP. Now, basically 40% is borne by the individual, okay, another 10% may be covered. So, if 40% deductibles are there, that is also somewhere controls the moral hazard. So, case 1, when deductible is actually is greater than that of QC, okay, you can see deductibles are even higher than that of, that is if that deductible is delta is greater than that of QC, insured person has to pay deductible amount for all the cost below delta and hence co-payment price, okay, and no incentive for moral hazard, and there will be no social loss. Okay. So, in this case, in the when case 2, when deductible actually less than the QC, okay. So, insured person has to pay deductible amount for all the cost below delta. In range above deductible and below co-payment, he has incentive for moral hazard and social and less social loss. Okay. So, there are other indicators of controlling moral hazard called monitoring and gatekeeping. So, we already actually discussed some of those examples earlier, like gatekeeping, how it is relevant. However, I am discussing some of them. Even we are also discussing in the other chapters. Insurance companies reduces moral hazard by confronting information asymmetry as well through supervision of medical care. Insured persons what is she is getting motivational or incentive programs for insured persons to follow healthy habits, like pre-event motivations. We will also discuss more about health systems with monitoring and keeping in unit number 7. Okay, so specific also importance are given in health system chapter, that is unit number 7. There are some evidence of moral hazard in health insurance. If you see, we cited the example for USA lab experiment, that is based on the RAND HIE suggests enrollees with more generous insurance are more reckless with their health. So, in that case you can just see patients with full insurance were 25% more likely to appear at the doctor's office or hospital with a broken bone or dislocated joint, 18% more likely to present. Now you can just see from the estimation the table, 18% more likely to present with some other serious trauma. This is given here, and now 35% more likely to be hospitalized for drugs, okay, drugs or alcohol abuse. Hence, ex ante moral hazard is explained. It occurs when those with insurance coverage take more risk. Okay. In Ghana, and another example, tendency of insured households having fewer people sleeping under mosquito nets than uninsured households. Okay. That one work identified, Ilma et al. 2012 paper. Health insurance decreases the cost of malaria treatment for insured households. Full insurance induces ex ante moral hazard. Another one is called preventive care and moral hazard, how it is controlled. Such as I told you, low use of preventive care means person is taking more health risk. This is found in Mexico's health insurance scheme called Segumo, popular in Salud 2003. And another case is more use of preventive care, that is exposed moral hazard problem, which you have already cited with RAND experiment, and RAND HI experiment and Oregon's Medicaid study. Both ex ante and ex post moral hazard effects arise when preventive care is covered by insurance. Offside of, another last one to discuss is offside of moral hazard, that is what if people routinely consume less health care than they should, and that may be because of ignorance of benefits of health care, inability to rightly judge the likelihood of rare events. Okay, there are income effects as well. The poor and middle class families can afford expensive treatments, can face expensive treatment. Persons may change his behavior by opting for expensive treatment that is well worth it, which he might not have chosen without insurance. Okay. So, that is all we have discussed, all possibilities of controlling moral hazard and how it is implying the families, the patients. So, to understand this in detail, we suggest you to read this book by Bhattacharya et al. As Health Economics in Bloomsbury publication. In the next lecture, we will be discussing on information asymmetry, and we will discuss the adverse selection issues as well. With this, I must thank you. You raise your queries, I will be happy to address it. Thank you.